يعني في الشيست ايميجينج جروب. هتكلمنا عن الريسنت ادفانسز ان بيت سي تي ايميجينج اوف لانج كانسر.
Good afternoon, dear professors and colleagues. I will try in the coming few minutes to rapidly review why FDG PET-CT imaging is an integral part in management of lung cancer patients, strengths and limitations, as well as recent advances in PET imaging of lung cancer. Any new development in imaging will have considerable impact on radiologists and chest physicians who are concerned with diagnosis and staging, as well as oncologists and thoracic surgeons who are concerned with treatment. And over the last 10 years, there have been important development in lung cancer management driven by improved imaging. And FDG PET-CT is considered now state-of-the-art imaging tool that is implemented in various international guidelines for evaluation of lung cancer patients. PET allows visualization and quantification of tumoral features on a molecular level beyond mere morphologic extent shown by conventional imaging, such as tumor metabolism and receptor expression. And the semi-quantitative parameter used in PET imaging is SUV, MTV, and TLG. And these features derived from PET imaging is used in lung cancer staging, therapy response evaluation, radiotherapy planning, prognostication, monitoring of recurrence, and detection of a second primary malignancy. Regarding staging, PET-CT is highly accurate for staging and identifying unsuspected metastases, and management strategies changed in approximately 72% of lung cancer patients. Regarding T-staging, it's helpful in detecting tumor size and location accurately, as in this case, presented with multiple bilateral pulmonary nodules and moderate to marked left side pleural effusion with almost subtotal collapse of the left lung. When PET imaging was done, revealed an ill-defined hypermetabolic mass within the collapsed lower lung parenchyma, and it was histopathologically proven to be lung cancer. FDG is also superior in differentiating between tumor and post-obstructive atelectasis, which is important in accurate local disease staging, percutaneous biopsy guiding, radiation therapy planning, and assessment of treatment response. As in this case, PET is accurately delineate the active tumor from the surrounding atelectasis. Another example delineating the actual size of the mass from the distal atelectasis with other hypermetabolic subcarinal lymph node. False positive results is found in inflammatory disease as tuberculoma and organizing pneumonia, and false negative can be found with small nodules less than 8 to 10 millimeter, invasive mucinous adenocarcinoma with reduced amount of cells, and minimally invasive carcinoma and carcinoma in situ. Also, false negative results is found in carcinoid tumor, which is one of the neuroendocrine tumor. And this can be solved by using a specific radiotracer, which is gallium-labeled dotatate, which is a specific tracer for somatostatin receptor, that is overexpressed in neuroendocrine tumor. This is a gallium dotatate PET show an intensely avid right lung carcinoid, and when this patient comes for follow-up after receiving appropriate treatment, the lesion becomes smaller in size with complete resolution of the dotatate avidity. In end-staging, PET-CT is also have high sensitivity and specificity in detecting nodal metastasis. This is a case of right lung cancer with mediastinal and right hilar FDG avid nodal deposits. But also we can find false negative and small-sized lesions and low-grade and low-volume malignancy, and false positive results can be found in granulomatous infections such as tuberculosis and sarcoidosis. In M staging, whether intrathoracic or extrathoracic deposits, PET can accurately detect the distant metastasis, and the most common sites are adrenal gland, liver, brain, bone, and abdominal lymph nodes. This is a case of metastatic right lung cancer. There is a right lung mass with nodal, hepatic, as well as sternal deposit that is not appreciated on CT images alone. PET also can detect unexpected metastasis, as in this case, right lung cancer with peritoneal deposits, and as we find the deposit is active and not well differentiated in CT images from the adjacent small bowel loop. False positive results can also found in adrenal hyperplasia and adenoma that may be mistaken for adrenal metastasis. Also false negative results can be found in necrotic lesions and lesions less than 1 centimeter, and also in brain deposits in which MRI is more sensitive than CT in detecting small deposits, as in this case. Early detection of biologic changes caused by decreased glucose metabolism is very helpful in detecting responder and non-responder at an earlier stage, and treatment can be adjusted on an individual basis. This case reveals how PET is important in detecting therapeutic response. This is a 70-year-old male presented with left lung cancer with right adrenal deposit. And after coming, after 4 months after treatment, we found that both the primary neoplasia and the adrenal deposit show remarkable regression in metabolic activity, although they have almost the same size on CT images. So there is a partial metabolic response in this case. Another case with right lung cancer, with left lung cancer with left hilar and mediastinal deposits, showing complete resolution of metabolic activity on follow-up images, although there is no change in size on CT images. Accurate delineation of the tumor by PET-CT can prevent mistargeting and unnecessary radiation to adjacent structures. Also, pre-treatment SUV max was found to be of no value regarding detecting the prognosis. However, high SUV max after treatment is associated with poor prognosis. And recent studies found that MTV and TLG have better prognostic implication than SUV. Also, SUV max is related to or reflecting the biologic activity of the tumor, as it is found to show high uptake of the FDG in aggressive or invasive tumors compared to carcinoma in situ, and minimally invasive tumor with very low tracer uptake. PET-CT can accurately distinguish recurrent tumor from fibrosis. Also, it is accurate in detecting distal recurrence, as in this case. This patient underwent right lower lobe resection for non-small cell lung cancer, and after coming 6 months after surgery, found to have a local recurrence in the surgical stump. Also, there is pleural, hepatic, and osseous deposits, and most of them are not appreciated on CT images alone. In about 3 to 4% of lung cancer patients, PET-CT can detect an incidental areas of increased FDG avidity, which are suspicious for secondary primary tumor or pre-malignant lesions, which change the management from curative intent to palliation in 27% of patients. This is an example of a patient with right lung cancer with incidentally discovered pancreatic tail mass. Another patient with right lung cancer and incidentally discovered right parotid tumor. Regarding recent advances in PET imaging, PET instrumentation has undergone steady evolution in both hardware and software. There are improvements in hardware, including new hardware incorporating designs with digital photomultiplier and fast electronics, allowing implementation of time-of-flight reconstruction. Also, manufacturers has improved PET sensitivity with larger axial field of view and 3D imaging, and new PET acquisition protocols have been enabled to include continuous bed motion, what's called total body PET, which is a recent technical development regarding PET scanner with long axial field of view covering at least the majority of the body surrounding the patient, with much more detectors in axial direction with higher sensitivity, as well as reduction of total acquisition time and dose requirement. Total body PET system were firstly combined with CT, as high sensitivity of these scanners lead to PET acquisition in time close to the speed of CT acquisition. But combining with MRI was suboptimal, as acquisition of total body MRI would be much slower than PET. Also, there is significant advances in the reconstruction software and on the CT component of the machines. With introduction of FDG PET MRI technology, PET MRI have reduced radiation exposure than PET CT. Also, it is superior in detecting pleural and mediastinal involvement, as well as detection of brain, liver, and bone metastasis. Yet, despite the variability of PET CT and PET MRI staging, both modality lead to comparable therapeutic decisions. Among the disadvantages of PET MRI is not widely available, longer acquisition time, and low sensitivity for detecting pulmonary nodules. Sorry. With invasion of artificial intelligence in field of radiology, FDG PET-CT radiomics is a quantitative extraction of imaging feature from medical scan, improving manual interpretation by detecting feature and patterns that would go unnoticed to human eye. And FDG PET-CT derived features has promising value in non-invasively diagnosing malignant nature of pulmonary nodules, differentiating lung cancer subtypes, and predicting response to different therapies as well as survival. Also, there are many novel radiopharmaceuticals that are targeting many processes rather than tumor biology, including hypoxia, angiogenesis, amino acid metabolism, choline metabolism, as well as antigen and receptor expression on the tumor. And these newly developed tracers described above might provide better insight to tumor behavior, broaden the applications and accuracy of this imaging method, and facilitating formulation of individualized treatment strategies. To sum up, the use of PET-CT has become a reliable tool that can complement and sometimes take place of conventional imaging modalities in radiologic assessment of lung cancer patients. PET-CT is a standard tool for diagnosis, staging, therapy planning, early treatment response assessment, restaging, and prognosis. Radiologists should be familiar with potential pitfalls that may encounter in their interpretation of PET-CT findings, and there is a steady evolution in software and hardware technologies with introduction of radiomics analysis and many novel radiopharmaceuticals improving various aspects of PET imaging. Thank you.